Good evening, everyone. I'm Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated, and on behalf of our General President, Brother Dr. Willis Lance III, good evening and welcome. This evening, we're going to be having a conversation with you. We want to talk about what's happening. We say that the body of medical knowledge turns over about 50% every 2 years or so. We're going to test that theory. And my two guests this evening and I are going to just have a conversation about what you can expect to be as with respect to the evolving trends in both medical care and in mental health. So without further ado, let me begin by introducing Alpha's Deputy Surgeon General for Mental Health, Brother Dr. Ron Kennedy Bailey. You know him as the Kathleen and John Bricker Chair, Professor and Head of the Department of Psychiatry at LSU Health Sciences Center. He is also the Chairman of the Board of Trustees of the Cobb Research Institute, and you know him as the past President of the National Medical Association. Welcome, Dr. Bailey.
Oh, thanks to be here. Good to see you, good brother Sterling.
All right. Also joining us will be Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha, and he's currently active in Alpha Eta Lambda chapter in Houston, where he practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. He's board certified in both internal medicine and geriatric medicine and is a fellow of the American College of Physicians and the Society of Hospital Medicine. So he will be joining us momentarily. And Dr. Bailey, let's just talk. I often talk a lot about empowering patients, and that's really a good thing because you only see your physician once every 365 days out of the year for the most part, unless you happen to be sick, then you see them more than you want to. But, I often talk about these themes about how to become a better steward of your own healthcare and how to be empowered in knowing your health. So to that end, the Dr. Google phenomenon has become a very real thing yet. So with that in mind, let's actually talk about that, both in terms of mental health and in terms of medical care itself. What do you make of the Dr. Google trend? Why don't you discuss how access to information has both empowered people and confused them? How should consumers actually distill all of this information? And we also want to talk a little bit about what's the best way for consumers to navigate the healthcare system, especially if you're using it because you don't have health insurance.
Well, thank you very much. I as well want to thank our General President, Willis Lonzer III, for convening this idea. I think it's wonderful. We mention regularly the value of a program for African American men by African American men to speak about our health and our community's health going forward. And I thank you as well, Brother Jeff Sterling. I've known you a long time, and you've done outstanding work, I think, in our community and really represent, I think, our class of 1990 so very, very well. So I commend you publicly also. On the issue of the question, I think that you hit 2 or 3 very salient points. I'm a psychiatrist. I think in our profession, discipline, maybe as much as any or more than others, patients come into our office with external outside information, whether they received it from a news source or a magazine or verbally from a family or friend. One of the challenges all too often is that individuals may challenge what the empirical data that the physician is sharing may say or recommend. That's not always to their advantage, but can always be a difficult concern, I think, for the physician, as it's really our responsibility to convey in an accurate fashion and an effective way information that's likely to lead that person toward better healthcare decisions. I do think that there's some key components of it that I think also should be recognized. First and foremost, the sheer volume of information that patients are exposed to can be pretty extreme. If you have your cell phone and you just kind of have it on throughout the day, there are pop-ups all day long. All too often, if you get a news feed sharing any number of considerations, sometimes they may even seem a bit conflictual. What you should do, what you shouldn't do, what you should eat or drink, what you should not eat or drink. One study says caffeine is good, one says caffeine is bad, one says eggs are good, one says eggs are bad. So I can imagine for a patient, and we all at some point fall in that category, it can be confusing, the non-linear approach of information as we actually receive it. So I think that's one consideration. Another, though, may be the fact that persons very often receive not only a second, but a third or a fourth or a tertiary type opinion that may actually challenge recommendations that they're getting, I think, from their primary provider. That's one thing when your providers are empirically based physicians, primary care as a specialist. Is another information you're receiving comes from a different source at your church or in your home environment, at your local YMCA or in your bowling league or amongst your college friends. I've had that happen quite a bit in my career. And, it's difficult as I might think that the information that person is receiving outside the empirical based information from, I think, the physician, myself, or the others on my team may actually be counterproductive for them. A third piece that I'll mention, and I'll end with this, is also often the idea may be not that what the person is receiving from their licensed physician is wrongful, just that that's information that may be additive or better. And very often I bring up the term herbals. Herbals or supplements come into that category. All too often patients come and doctor, look at this article I read. Should I be adding these herbals? And at times, the herbal by itself, even if tested, may have some value. St. John's wort, was a very popular one almost a decade ago in my profession. But we recognize, I think, in medicine that if you're using a variety of outside substances, toxic or otherwise, they clearly compete for binding sites. So the more items you're taking, whether you're eating them as food or nutrition or supplements, the more likelihood that everything you're taking may kind of go away in the wash because the competition for binding sites, especially at the liver and other areas, I think, of metabolism, are overextended. So those, I think, are three considerations that very often come to mind for me when we speak about information, what may be the overload of information, the prospect of misinformation, and how we handle information that I think patients receive that may or not affect the effectiveness of the best choices of care that we optimally give to them.
You said a lot there, and that's pretty powerful stuff. So as we go along, I want to make sure that we're distilling this down to a level to where the audience actually can have tools to really understand not only what we're saying, but how they can take it home with them and use it. So in basically, that's why I started with the notion that, so much of the body of knowledge in medicine turns over so frequently. So if you are the type of consumer out there that remembers something that your grandma told you, and we get this a lot, and no disrespect to anyone's grandmother out there, that information may not only be misinformation, but even if it was accurate information at some point, there's a pretty high probability that the information is dated. So, we like to joke about Robitussin and stuff like that, but truthfully, you have access to more accurate information. So the Dr. Google phenomenon is actually, in my estimation, a good thing as a starting point, but medicine is not linear. It's not, I have symptom A, symptom B plus symptom C, and therefore I have Ebola virus. And believe it or not, people come to me with that kind of stuff quite often, as you know. People really need to become better at not trying to use the internet to interpret their symptoms, but perhaps the best use is to use the information that you get online and elsewhere to kind of figure out when you should interact with the medical system and to know what types of questions you should be asking your healthcare provider. So if you just do it that way, and this is even perhaps equally, if not more dangerous when it comes to mental health, because people love self-diagnosing and, they'll come in and tell you, oh my God, I think my sister has schizophrenia. Can you commit them? So these are the types of things that are not to be taken in a joking manner because they're very real and people get stressed out over them and people do things to try to self-medicate or otherwise engage in interventions that really can be harmful. So just kind of keep that in mind, if you will. I want to seg from there to something that the consumers can actually do that is helpful. One of the recent trends that, I've actually been championing this for about 15 years now, and well, actually more than 15 years, but the prospects of what you can acquire via telehealth and telemedicine, these are trends that are very good. Overuse of emergency departments and inappropriate use of emergency departments have been things that have existed forever. There are those that will claim as long as you have emergency departments accessible to you, and you do by law, then you actually will always have a way to enter the healthcare system. But truthfully, it's a pretty bad place to enter the system. If you wait until you have severity that necessitates an ER visit and use that as your portal of entry into the healthcare system, even under the best case scenario, we're now talking about sick care as opposed to anything related to health prevention and health promotion. So what I would advocate for you consumers out there is that, first of all, if you have insurance, it's easier than if you don't. But if your insurance actually offers you a benefit to where you have access to any of the various dial-a-doc modalities out there. Free telehealth, which is information and advice, versus telemedicine, which is the actual treatment, diagnosis and treatment of diseases, complete with you maybe getting a prescription. These are things that you really should be trying to, in 2023, to take advantage of. You want to comment on that or add to that, Dr. Bailey?
Absolutely. I would add that I think being aware of source of information, I think, is key, stated earlier. But I think most importantly, being able to decipher where to go to receive, I think, a vantage point that I think is scrutinized and assessed, I think is key. You mentioned, someone's grandmother. My 82-year-old mother lives with me now, and I'm going through, I think, a learning process of appreciating how much information she receives, what she understands, what she thinks about that particular information, what level of trust or confidence, what you see some other settings, as well. I think, as you say very clearly, what I think has been born over time, that a level, I think, of comfort has developed, including something that may not be optimized or may have changed, getting to this piece about body of knowledge, but that she's experienced it over many, many years, I think, in the past. So why many quote unquote old wives' tales last and linger in our community, I think, is based on this consideration, and why I think there may also be a challenge in sharing new information or changing behavior, I think, in our patients. As a psychiatrist, we take a lot of pride in this idea to change behavior. I don't know that we have a perfect tool or strategy to do so. We probably are asked to do it in at least as much as any doctor in medicine. The classic issue is alcoholism. My entire 30-year career, patients to me to kind of stop or deal with or address or treat alcoholism, which is classically a volitional, purposeful behavior. Same issue with medication compliance or lack thereof, or what kind of behaviors people are involved in, from their diet to the exercise or not, that we recommend. So these ideas about receiving information, having older information that we're comfortable with, whether it works or not, be willing to change or adapt or amend your understanding going forward, or to how we receive, acclimate toward additional, newer type items, information, I think, is key. A few data points. I mean, the data would argue that African patients, for example, especially men, are more likely to feel comfortable talking to an African American doctor, especially another man. We do see numbers like this in this direction with other demographics, but probably none, I think, as strident as we see with African Americans, maybe because of the issues of trust, distrust, and our country going back a long time. So that, and we should be mindful of that, I think, as physicians, I think, across the board, and we should, I think, try to maximize our ability to assist that person from receiving information that they're likely to benefit from and change their behavior. So if there's an older African American male, an alpha or not, if that's your relative or friend or neighbor or coworker, try to find a way to not only give information to them or get them to the right place, make a referral, but ensure that they actually are hearing in a way that they can actually trust how what they're being told, and that then they will probably make the maneuvers to change their behavior in an effective way. I think these are strategies that are likely to work much more effectively and lead to better overall outcomes for men, I think, in our cohort.
So, once again, as consumers, the idea, just like we talk about when you're trying to work out or go on a diet, accountability partner is a good thing. And if we can use these current trends toward greater access to information to help our families and to hold each other accountable, that's a good thing. One of the things that I really want to impress upon you is, let's disavow ourselves of the notion that there are stupid questions or inappropriate emergency department visits, or especially telehealth and telemedicine visits. The way that your benefit is set up, anything that you can do to engage the healthcare system via telehealth or telemedicine is more cost effective and may be a better use of your time than going to an emergency department, all things being equal. However, part of you learning how to know what right questions are to ask involve a very simple consideration. There's a law in the United States called prudent layperson. So forget what I just told you. If you ever feel sick enough that you feel as if you need to engage the healthcare system or go to the emergency department, do so immediately without a second thought. As an emergency physician, I'm in the no news is good news business. So I'd much rather you came to see us and had us tell you no. no news is good news. Sometimes you have to take "you're okay" for an answer, and people always want us to find everything that's going on. In an emergency department setting, we're looking for life threats. So if I tell you that we didn't find what we were looking for, that's a lot better news, believe it or not, than me telling you that I did find what you're looking for, because in the emergency department setting, we're looking for something that's trying to kill you. So use the emergency department more, use telehealth and telemedicine more, and help out your family by making sure that they have access to the resources. And when it comes to diseases like strokes and heart attacks, we say time is tissue. Do not delay. Once these symptoms start, we literally need you to come get taken care of, because we'll have the best opportunity of taking care of you the earlier you present.
I definitely think that this idea of early intervention is better, makes sense. Literally today, I was in a meeting with a group. We're going to start writing a piece monthly about mental health and assessments. So I think that there is a need for a better baseline or foundational understanding of mental health concerns in our community. I live in New Orleans now, and if there are three huge problems around the country, they all are, magnanimous in New Orleans. I mean, there's a lot of violence. There's a lot of response to disasters. Think Hurricane Katrina, Hurricane Ida a few years ago, and then there's a lot of homelessness. So I mean, probably three of the biggest problems we have in our society, we see, I think, on steroids being argued here in New Orleans. So this idea that I think we've got to find ways to communicate more effectively makes sense. But I love this discussion about how patients can, I think, maximize the use of the resources they actually have when they, I think, integrate in a healthcare medium. Because as you point out, what you do, I think, in emergency medicine is essential, and it should not be overused. People should realize when you get an assessment from an ER doctor, they say that you're fine, you can leave. That doesn't mean that you don't have any problem at all. You just don't have an emergency problem that's urgent,
Right.
and as you mentioned, that's trying to kill you right here today. Psychiatry is just the opposite. So we probably different ends we do all of the long-term stuff. Rarely do we make a treatment intervention that's going to fix whatever your problem is today, or this week, or frankly, this month.
There's active suicidal ideation, but beyond that, yeah.
Remission is usually 6 to 12 months. We don't say that you haven't totally failed until you've had depression for 2 years or more, and then we call it dysthymia. So I think that for patients and people in our society to understand, especially in our community, how these metrics work and what the goals or the targets are with different type of physicians, whether it's ER on one end of the spectrum or psychiatry on the other, I think it's essential on them having a positive outcome and feeling informed and educated about, I think, educated consumers of the healthcare process.
That's right. But I want to put a caveat on that, because, again, there's a substantial amount of psychiatric illness that actually has what we call an organic basis. So there are medical conditions that actually manifest themselves in behavioral abnormalities. So even with that, if you and your family start having abnormal symptoms of any type, whether it's mental or physical, the emergency department is a really good place for you to get that evaluated. Or if you have access to a phone and a computer monitor, telehealth, telemedicine, keep that in mind. I got a couple more questions, but as we go along the way, I want to acknowledge the people that are making comments and in the chat room. So yes, we hear you. We will get to your questions as well. And yes, Igor, particularly when it comes to considerations such as heart attacks and strokes, those are clear issues in which, if we get to you within a defined time frame for each of those two entities respectively, the data is just so much better in terms of what your short-term outcome, long-term outcome, and ability to avoid death is. So we'll talk about what those symptoms are, early recognition, in the upcoming session. But by all means, don't ever feel like you can sleep it off overnight, because, by the way, in the example of strokes, most strokes are diagnosed the next morning after you've had that stroke cooking inside of you for the middle of the night, and your family wakes you up in the middle of the beginning of the morning and sees that something's gone horribly wrong. So keep that in mind. I'm going to stay on this information track, because that's really a big part of where medicine is going in the quest to empower consumers. I want to talk about TV ads. Let's try to explain TV ads, because there was a time when these things were actually prohibited. So the types of questions that we're going to talk about right now that we want consumers to appreciate, you probably wonder, do physicians actually listen when patient comes in with information off of TV? Because you got to remember, these ads are not consumer information, they're marketing tools. So that's something that you need to start off with. And of course, we have to address why there's so much emphasis on all those side effects and whether or not the drugs that they're offering up on TV really are that dangerous. So before we get into that, I'm actually going to welcome Dr. Deputy Surgeon General Narcisse. Good evening.
Good evening.
I want to jump right in on you since you're there. I just asked the question before Brother Dr. Bailey gets in. We were just talking about TV ads. And the question on the table is, do physicians actually listen when patients come in with information off of TV? And what's the deal with all the side effects? Are drugs really that dangerous? And if they are, why are they allowed to advertise them the way they do? What are your thoughts on that?
Thanks so much. So the drugs actually do have the side effects that they talk about on the ads. But the issue that doctors struggle with is that patients are given information, but not necessarily all the information that would be needed to make the correct medical decision. And so the doctors end up spending a great deal of time unlearning a situation that probably shouldn't have been present in the first place. And so a physician's time is very, very valuable. I think everyone understands that. The physicians value the time that they have with their patients. And when a substantial amount of that precious interaction time is consumed with an information relearning that it's unfortunate. Most of the time, I find that patients that are bringing information to me are bringing information because they hope that there's something that can be done. And very rarely have I made a decision based on the information that the patient gave me that I didn't already know before. So I would tell you that the TV ads are not for the physicians. It's to drive the demand for consumers to bring information to physicians. And they're effective. That's the reason why the pharmaceutical companies spend so much money on these ads. But I find that they're very disruptive to the patient interaction.
Yeah, I'll jump in. I mean, in psychiatry, I think you're right, Vic. And we glad we have you. I think that you're right on target. We struggle already, as I mentioned just earlier, getting patients to believe in what we're saying, and at least, if not hear, not be overly responsive to what I call the outside noise. Let's take herbals, or the meds don't work, or you're against pharmaceuticals, or I don't take medication, I just want therapy. Patients don't usually say that when they have pain and they have cancer or diabetes or hypertension. They take meds. Why does this psychological barrier to take medications from pharma companies when it's about mental health has always been a challenge for us? But the perception trumps reality. It is real, and we have to kind of deal with it. So I think you're 100% right. This idea that direct-to-consumer advertising works. It does work if the goal is for the pharma company. They have patients come bombarding people like myself and I'm saying, I really want this med. Well, part of the struggle, I think, is threefold that patients should be mindful of. Drugs are generally tested against one comparator, placebo, the case may be. And many patients, most of my experience, are taking more than one treatment. So you really are not in a comparison of apples versus apples, because you're already on medicines for A, let alone A, B, and C, and you're deciding to take something that's been shown to be effective only compared to nothing at all or placebo. That's one issue. A second issue that very often we use very sterile environments. We don't have always have what they call open label studies. So in a study setting, I've been doing studies my whole career. Often the patient didn't use alcohol or drugs and didn't have a major medical problem and took it consistently and what have you. And we'd always have that in the real world. So patients don't get the same experience as you saw in a clinical trial because they don't actually have this perfect scenario, I think, for care. And the third point that I think is often so important that I think patients should be mindful of is there's always this value of the white coat phenomenon in clinical trials. The simple fact that you're going to go to the clinical trial, you're going to go to the hospital or to the clinic, and you're going to talk to the doctor, and that person wants to say something that's very positive. The doctor wants to hear, it's a good response, and you want to say it. So that underlying positive sense, I think, of acclamation often overrides what the patient is actually really experiencing. So you may actually think, based on what we've read, what we hear, that the likelihood that medicine is going to work better for you is the case. So you should work with your doctor in a one-on-one setting. I like the idea. The so-called the N is always of one. The number of people in the study that matters to you is yourself, and your scenario may be a bit different than others. You should have confidence in what the empirical data says, but do it, I think, within reason over time, working with your doctor. Those are my best considerations, I think, kind of going forward, especially as it pertains to TV advertising.
So the goal with every one of these topics that we brings up today is for the listeners, the audience, to be able to take something with them. So let me just ask this question very carefully, and I want you to be thoughtful about this. Have both of you, and I'll answer the question myself, have any of you ever changed a medication regimen based off of a patient coming in to you with something that they saw on a TV commercial about some medication?
I can answer that pretty clearly. That's not what usually happens. I find that the information that the patients bring is very unpersuasive to my medical decision making, because the TV ads cover just the most superficial positive aspects and the superficial negative aspects of the medication. And as Dr. Bailey was mentioning, those medicines were often studied in a slightly different environment than the patient is standing before us today. And I just wanted to put a 10-second plug in. This is one of the reasons why it's so important for members of our community to participate in medical trials, because you don't really know if the medications that are being studied are going to work in populations like the ones that I take care of, unless populations like I take care of participate in the trial, and that means us.
So not at all a common phenomenon. I obviously have not. So I just want to say to the audience that you don't reverse engineer medications into your treatment regimen. There are standards of care that physicians use to identify what the best medication is for you. So probably the best use of these commercials really is to empower yourself with information. If you have a question about something you saw on TV, or it mentions something about your disease that you want some follow-up on, have that conversation with your healthcare provider. We'll be happy to do so. But more likely than not, we just don't treat, this isn't a grocery store phenomenon where you come in and say, hey, I saw this great medicine on TV, I want it. It's never going to work like that. So don't ever approach your physician with that type of expectation. I want to do one more question on this information piece, because it really is such an important part of trends in healthcare these days. And this deals directly with something that was touched on earlier by Dr. Bailey. There is this reticence in our community about information, about sharing information, about entities like the government having access to our information. But one thing that I will tell you is that if you access one of these apps that actually allows you to store your medical information and to have it with the press of a button, your allergies, for example, your surgical history, your diseases, because so many of us don't know. And so many of us have present to hospitals or our physicians with entities that incapacitate us to the point to where we can't express exactly what's going on. So there is tremendous value in your having, whether it's a manila folder or something on an app that actually speaks to your past medical history and your family history and your social history, whether you drink or smoke or do drugs. The more we are involved in a guessing game, particularly in an emergency department setting or any other type of life threat where we have accurate information, the better off it's going to be for you. So I'm going to invite both of you gentlemen to speak on your thoughts about using information, and thanks to Still Bill out there for wanting us to talk about that. And he actually framed the ask in terms of our reticence in doing so because of the traumatic effects, the mentally traumatic effects that we've had from enslavement and systemic racism, and maybe not necessarily wanting to share that information. So have at that, and let me hear your thoughts on what consumers can do well to make sure that they always have their past medical history at their fingertips.
I can go first. I think that I take care of medically complex older patients, adult patients. And so it's very common for individuals to have a large number of medical problems in their past medical history, a large number of surgical problems, a large number of medicines that they're taking now, medicines that they've tried in the past and had problems with. And the better I can obtain that information, evaluate that information, and apply that information to the person, the better that is. The problem that I worry about is that, who has access to that information? Is it just you, or is it your family, or is it the owners of the app, or the owners of the app who might wish to market that information?
Yeah.
I think there was a recent example of a therapy site that was accused of marketing the information from its clients, and so whether it's your DNA, or whether it's your past medical history, or whether it's you drink or use drugs, or who you love, I think that it's really important for you to have access to that information, but only the people that you want to have access to the information should have it.
Yeah, Ron, I jump in, and I certainly agree. I clearly think that one thing we all are learning, some of us, myself included, maybe later to the game than we should be, is that the new era and genre and generation, I should say, that we're in, with free and rapid access to so much information, can simply be abused. And this is certainly one of those areas. I'm like Dr. Narcisse, very surprised at times at how easy it is to access so much information, and how it can be misunderstood, and if not so misused. So that some individuals on one end of the spectrum not want to let anything out may be excessive, when more information can be beneficial if it gets in the right hands at an appropriate time. But the other end of the spectrum can also, I think, cause problems. So my recommendation to patients all too often is to know your story, ensure that there's a free and unfettered list of access information to the doctors who you choose. I think the consultants, as well as your primary doctor, must understand the full story that you actually come in with, your full history, your full family history, what's worked or what has not worked. I think in information we understand now, in a genome plus era, the more we know about somebody's past history, the data we actually have may give us better direction as clinicians and physicians on going forward, what's likely to work or work better in that setting. I'll give an example. I'm a 58-year-old man, with back pain pretty regularly. Not enough to make me dysfunctional. I go to work every day, but it clearly doesn't impact me. I play golf, my hobby, a lot less than I did in the past. But the truth is, other had not one but two arthritic-laden hip replacements. And both my uncles have had shoulder arthritis as well. My doctors being aware of that has helped guide my treatment plan kind of going forward. I probably have had a better recommendations on the treatment plan that's helped me, I think, clear, faster, and function better. So access to information has been essential in helping me, I think, give a lot effective in receiving the treatment that healthcare has to offer at this point in my life and my career. So it's one example, my personal one, in one area, I think, of my health concerns that I'd share with the public, because I think that it's important for the public to know that as physicians, we also struggle with the same consideration of how much information should be addressed and understood, and what other areas, what information that should be manifest to our treatment providers. I'd encourage those listening today to use that to your advantage and be operationally effective and the lead consideration, I think, on your own healthcare information.
I'd like to just put a plug in for one piece of information sharing that we don't do enough of. We've talked about it on this web series before, but as you have family gatherings, you should speak to your family members and understand their medical problems, not to try to get nosy or to try to be in their business, but so that you can better understand how a family history might affect you. If someone in your family has breast cancer, or has had colon cancer or pancreatic cancer, or early heart attacks or early strokes, that might affect the decisions that you and your doctor make about medications, therapies, and treatments for you. So I think that having an open conversation in your community with your family members, particularly your first degree, second degree relatives, I think is essential. I still favor having a piece of paper with these things written in your purse or in your wallet, so that in the emergency room or a family member can easily access that. And I worry about, I had a family member this last week who was trying to access their husband's medical app through their portal, but they just didn't have the Face ID, they didn't have the password, so they had the device, they had permission. They just couldn't physically get into the app. So I worry about that technology, as I have I have older family members, parents, not quite grandparents, but parents who are not as tech friendly. And so when the stress is on, can they get into the app? Can they get into the phone? Can they get into the device?
So the point to be made there is that we're not advocating technology, but some mechanism, multiple mechanisms of making sure that you have access to your medicines, to your past medical history and other considerations is a very important point to be made. And obviously, this is an even more vital consideration if you or your family, whoever's coming to the emergency department, is in the midst of what is being perceived as a life threat. You know, your family practitioner may have more time available to help you gather these things, but in the setting in which you would come to see me, you might want to have that stuff well organized. And it actually is easier to have it organized in paper, but just be aware that these other things are going on. And yes, very good comments coming through. Thank you for that. Don't forget to always bring your meds to you in the ER. And one of the things I was expecting Dr. Narcisse to say is that in the older population, folks are on so many different medicines. It becomes critical for us to know that, because drugs have interactions with each other. And before we start pumping a bunch of new meds into you, it's critical for us to know what those medicines are. I'll comment also on a comment from Tiffany Golden out there. Thank you for the comment. You know, in my setting, in the emergency department setting, the question basically is how do we know and how do we find out if a patient has some type of electronic medical record or other database that can be accessed? In an emergency department setting, you know, it's a crapshoot. We actually aren't treating your medical history as much as we are treating your symptoms. So we call it the sticker on the forehead phenomenon. If you come into an emergency department with chest pain, for example, that's the sticker on the forehead. And 80% of what we're going to do is based on best practice protocols related to that disease and what the life threats are. What you bring to the table with your past medical history helps us get closer to the point more directly. And there's nuance involved with the different interventions that we would engage in. But for the most part, if we don't have access to the information immediately, for example, if the emergency department doesn't share a database broadly, then we just go with what we have. And that happens more often than you would think. I would want to switch gears. And I want to toss this over to Dr. Bailey, because the mental health part of this conversation is quite fascinating. Look, our view of mental health and behavioral norms have changed pretty dramatically between generations. Quite frankly, I remember things that would have once gotten people placed or received electric shock therapy. We're all old enough to remember when that was actually in vogue, and then straitjackets, and then restraints, and things have changed. So behavioral norms have changed pretty dramatically. Dr. Bailey, just discuss, if you would, the extent to which science producing evolving societal views versus, and this might be controversial, but how much societal views actually direct what's being researched and how we're discovering what is happening with things that once upon a time were considered deviancies.
Right. Oh, well said. I think that there are several key areas. I'll address a couple of them. The first that catches my attention is the entire opioid epidemic, words on a pandemic. The reality is, early in my career, I keep saying 30 years ago, at best we had a treatment called methadone. It was very often that it was icky to people. You had to go and go liquid, not pill. You had to go to a hospital and had to go at 6 o'clock in the morning when nobody else was around, and you had to go to a back door and somebody would open a window and kind of push it out at you. It wasn't mainstream. The reality is there's been an explosion of Americans worldwide, really, taking a prescription from a doctor, pills that hit the mu receptor and treat pain, chronic pain. Probably the most common that's described is Vicodin, but you go to your dentist and get, Stadol. You go to your primary care doctor, whoever, get everything from Percodan, the like. And of course, with the explosion of OxyContin, this problem became, I think, manifest. At that point, as I think you say very articulately, Dr. Sterling, our federal government got involved and allowed more money to support grant opportunities to look at, I think, different strategies to address this growing opioid epidemic. This started over a decade ago, probably maybe 2 decades ago. And lo and behold, we produced better treatment. Now we have buprenorphine, which is called Suboxone. It's mainstream. Your regular doctor in their primary care office can write your prescription like any other medicine or insulin, or the case may be. You can actually take it in strips up under your tongue, and you can kind of take it long. So we've certainly de-socialized the anti-socialism consideration, if you will, sociological, excuse me, and we've made it much more mainstream, in part because I think we have a better treatment that research, I think, has produced, but also I think we view differently the issue of having an opioid dependence. So one of my best examples, I think, of how we handled this better, more correctly, we didn't use stigma. Very often raises its head, I think, in mental health and in psychiatry, that adversely affects individuals' ability to receive any care, let alone optimize, and for them not to feel bad about themselves and be ashamed and embarrassed that they have a medical problem that requires treatment or care.
No,
I had it. Oh,
no, please go ahead.
I was going to say, Dr. Sterling, I have another example, HIV. When I was a young medical student, HIV was an epidemic that had very few treatment options, and there was very little appetite in broader society to do research and to try to find ways to help individuals who had been affected. But a young gentleman named Ryan White became affected because of no fault of his own. He had a disease that required frequent blood transfusions, blood product transfusions. He ended up getting HIV and later AIDS, and as a result, this story changed the public narrative around funding for HIV, and all of a sudden, HIV and AIDS was a national priority in terms of research. So I think that the way that society looks at issues certainly affects the politics of research, the politics and economics of research in very, very dramatic ways. And the activism that individuals have to say that this problem is important in my community, that was HIV. You know, what if we did the same thing for sickle cell anemia or other problems?
Yeah, you opened the door up, so I'm going to drive a truck through it. I think an even better example than what both of you gentlemen have posited in the context of the question, which is how does society drive research, and how does reality change what we once thought was pathologic or aberrant behavior? And I'm going to toss this back to our resident psychiatrist here. Let's talk about homosexuality for just a couple of minutes, because truthfully, the research on homosexuality has just been absolutely fascinating to follow. And that is a clear example from something that a couple of generations ago was viewed amazingly differently than it is today. So if you would, just give us a minute or two on, it's impossible to do, but I'm going to ask you to do it anyway, on just how the research has really guided an understanding of what homosexuality is, and how there's been this feedback loop into public policy and a better understanding of why people are that way and now are allowed to be that way, relatively speaking, of course.
Well, I think you're right, Dr. Sterling. I think that it actually is an area of discussion to kind of drive a truck through, because it is kind of a sine qua non issue of how policy and politics have played a remarkably important role in healthcare, how we fund it, what we spend money on, what we choose to research, how we even interpret the research data. I'm a psychiatrist, you kind of pointed out, and I think 9 was the year. It definitely was the better part of 3 or 4 decades ago now, not just 10 years ago. The organization used to be on the board of trustees. American Psychiatric Association voted on whether homosexuality was a disorder or a disease. I mean, literally took a vote in open public, if you will. A lot less data then than we have now on many, I think, of the health concerns that may come into play of individuals who describe themselves as the sexual orientation as being like sourced. So you make a very important point that we should appreciate the role that, as I said earlier, politics has played. We as physicians should be very mindful to remain strident in our approach evidence-based and empirically oriented in the decisions we make and how we make choices on healthcare and what information we give and determination we make for treatment planning, I think, for patients. We have to be aware, mindful that these political winds can occur because in one direction one time, they can sweep in the opposite direction at a different time, which is perhaps the point you're addressing. Now, homosexuality is fully embraced in organized medicine, organized. We don't see it as a disease in of itself or a disorder, something to be labeled or diagnosed or treated that you're going to make somebody kind of change their action or behavior. We see it as a sexual orientation, of which there are more than one that humans of all backgrounds may produce. So the reality is to be mindful of this and wise and not allow it to harm patients.
So let me just put this in the context, because I think this is important for people to appreciate as a way of understanding trends in medicine and where medicine is going and how medical considerations evolve. You know, the back and forth between politics, research, and recommendations is such that in this particular example, the political pressure that was put to bear on the research community allowed discoveries to be made that really created a much broader understanding about the inherent nature of homosexuality in some individuals. And because of that, that has driven the conversation as opposed to simply that's being done to curry favor with a political constituency. There really do appear, according to research, some inherent considerations in that particular scenario. And it's just amazing how a couple of years ago, there were those that wanted to pray the gay away, for example. And before that, as I mentioned, we would have engaged in electric shock therapy and other what are now viewed as barbaric ways to address with aberrancy or pathology. But let's continue on.
Can I give just one more example?
Sure.
It's a little bit further in the past, but there's we now would call it pseudoscience called eugenics. And the idea then was that there are certain individuals, certain ethnic backgrounds, certain racial backgrounds that were better than others. And there were individuals who had this political view, and then they tried to create science to justify this worldview. And they did things that we would now see as not credible science, but at the time was touted as groundbreaking work. And they measure things, and while that the 1920s and the 1930s sound like it's such a long time ago, I think that we still have a collective impact of the ideas that certain groups are better than others, and I can prove that based on some kind of research that we would now really describe as pseudoscience or junk science.
Sure. We're going to go into the rapid round here. Programming alert to everyone. We'll be doing this for another 15 minutes, and we have quite a few topics that we want to get to so that we can empower you with information about trends occurring in healthcare. So I want you guys to see if you can give me 30 to 60 seconds answers to some of these considerations. And if you can't, you can't, because these are really difficult topics. And just to prove that point, let me come back to you, Dr. Bailey. One of the breakthroughs that's occurred in mental health these days has been allowing men to be more expressive and to have more emotional range. This is more of a sociology question as it is. It's as much of a sociology question as much as it is a psychological question. But where's the line these days between having a safe space for venting and actually becoming mentally weak, if indeed that's a thing? There's certainly a better ways to describe that characterization.
Yeah, briefly, I'd make the argument that the tenor of your question is accurate. We do see along a continuum that there may be change. I'm impressed with some of the questions we get from young men. Questions that, as you point out, early in my career, a young man wouldn't be caught either verbally or putting in the chat because of the concept that there would be this negative connotation, being weak or like. As Dr. Darcy said, the other consideration is, I think, in the Black community, we've also historically thought in psychiatry that to be good with psychiatry, you couldn't be good with God. And there was a religious and a spiritual foundational breakdown that had to exist in order for you to go see a psychiatrist, let alone to take the medication or the treatment, i.e. this concept of differentiation between the mind and the brain. I think much of that has been challenged. I think many individuals have much more of a progressive and a broad-based perspective, more willing to go and see a mental health professional, social worker, psychiatrist, whether they're Black or otherwise, and receive care and take that care going forward. I would add, though, that there still are stigma issues at play. Psychiatrists are most likely, unfortunately, the person to go to a doctor and get treatment and get a prescription, never get it filled the first time. That has to be something between our ears. Even after we get a prescription that may help us, we choose not to go into some other aberrant hurdle. Those are issues that we should speak against.
So for members of the audience, again, a take-home message is do not be afraid to engage the mental health system. You can get both tools for stress management, stress reduction, empowerment, as well as any other resources that you may need. So let's not worry about being called weak or feel like your manhood is challenged because you actually are seeking help. Next question is going to go to Brother Dr. Narcisse here. After decades of improvement, life expectancy in the United States has actually dropped in consecutive years. And that's probably the first time that's happened in recorded or our lifetime, certainly. Early on, this was attributed to COVID, but there's a lot more to do with the drops in life expectancy than that. Discuss very briefly, if you would, why this could be very bad news over the long term and what we should be doing to combat this. In other words, we've gotten past the place where we can blame all of this drop on COVID. So what does this portend for us in the future?
Well, we certainly lost more than 1 million individuals to COVID, and I think that's certainly the early part of this. But I think what you're describing is the realization that the lifestyle choices that we've made that have led to obesity, to diabetes, to high blood pressure, high cholesterol, all the foods that I love to eat from New Orleans, as a good good son of New Orleans. All those things have deleterious effects on our lives. And then when you add to it the mental health issues of drug abuse and of suicide, I think that there's a whole panoply of problems that we have not truly managed well. And I think that we have, shame on us as a society, we've spent more money on healthcare than most other Western societies, but we have not received the same kinds of benefits. And so the types of things that we know work well, vaccinations, cancer screening, control of cardiovascular health, I think that those kinds of things are very, very beneficial and highly underutilized. And I strongly encourage anyone in the sound of my voice to take advantage of those resources with their physicians, make a plan, and then bring your family members and have them make their own individual plans. I think that that's going to be very, very important because if you look at Japan, China, those societies are actually seeing more deaths than births, and I think that this is something that would cause tremendous social upheaval in the United States.
So once again, the questions are coming in hot and heavy, and just fantastic job on the questions to members of the audience. Part of this challenge, the question actually reads, it's kind of answering itself, do men really know how to set healthy boundaries? Well, the answer to that is that healthy boundaries are as healthy boundaries do. And our challenge and your take-home challenge is to engage your family members and the men in your life such that they feel more comfortable, that they have a safe space in which they can know how to express themselves and to have those healthy boundaries that have expanded in the ability to express their mental health concerns. And to Tiffany Golden, is suicide depression part of this drop? Disease across the board affects African Americans now. Again, of the top 10 causes of death in the United States, 9 out of the 10 affect African Americans more than the general population. We tend the one that isn't is suicide, and that flips with homicide in our community. But the suicide rate is clearly on the rise across all demographics, and is something that we need to continue to be mindful of. We invite you to continue to watch this space for Dr. Bailey's excellent conversations on suicide, depression, and other mental health considerations. This next question is going to go to Dr. Bailey, because I'm going to stay on this theme of what I just said. An ongoing and under-addressed public health crisis is police violence against the Black community. Medically speaking, how does our community, with what I would describe as a historic post-traumatic stress disorder, best combat the perception and the reality of this omnipresent threat? And again, I said two things: the perception, because our heart rate goes up, is the reverse of white coat syndrome, where you get, well, actually it is white coat syndrome, because your blood pressure and your heart rate go up in the presence of these guys. So how do we avoid the stress of that scenario, and how do we avoid as a community the reality that in fact in some instances we have been targeted and taken out by the worst of that crew?
Well,
in the context of a public health consideration.
Right, it is absolute public health consideration. As a psychiatrist and a person who specializes in this issue regarding violence, I'm very pleased in 2016 when the AMA joined the American Medical Association, joined the American Psychiatric, which had done it years before, and calling violence and the qualitative violence as we see in America now a public health problem. Just like you put fluoride in toothpaste to address everybody comprehensively in a proactive, preventative type fashion. We should do the exact same to avoid cavities. We should do the exact same for violence. I was on a program here recently, and we discussed the fact that I believe we should be talking about this issue preventatively to all of our young people. I think in every school, in every class, in every church, and in every YMCA and community health center, this should be part of the discussion, just like regular health, just like general education, just part of our history, because all of us have some degree, I think, of relative risk. I also think that the issue of police brutality has a unique role to play. There's unfortunately a history of some areas of law enforcement being more, and for what I've read, even geared initially to, harmful toward the black or poor communities of blacks and browns. And unfortunately, some of the vestige of that has continued over time, especially in large urban areas and areas where I think there are a large number of ethnic minority persons. That's objectionable to me, and we should, I think, attack it from every angle. I think the government should change laws and rules that I think are disadvantageous and adverse to some, like higher prison sentences for having, crack cocaine compared to powder cocaine. Other universities should address in the academic sphere. Should fund grants at the national and state level when persons are trying to look at violence and see it as a key element engaged in. Dr. Suru point when he said earlier, we often don't fund sickle cell anemia, for example. We might fund taste these others. At the government level, would engage in activities that I think often show a bias that I think in the long run can be harmful. Police brutality is one of several variables in the setting, but one that I think comes to mind.
So I would just offer a couple of quick practical tips if you can afford such things. These days, I'm shocked and pleased that the body cams became a thing, requiring police to wear these things for these interactions. But also, there are things that you can do. There are pretty inexpensive now versions of car cams that you can use to record these interactions. And if you're quick enough, before you put your hands on the steering wheel, you really can set those things up. And even something as simple as your iPhone, and I don't know if Galaxy does this, but I forget what they're called, but you can actually set your phones up to record what happens over the next several minutes, to call somebody, letting them know that you've been stopped by the police. The point of this is to make sure that you are empowered and to know what you have at your disposal to ensure that you are protected in these situations. And hopefully that will alleviate some of the stress. And as a general consideration, coping mechanisms. Look, we talked about this a few months ago. The best way to deal with stress is to avoid it. And, there's a lot of space between avoiding stress and having to have stress management techniques in play that you wield successfully. So, learn these things. We'll get into them in more detail on subsequent talks, but this is out there and it's kind of important. You brought up something, Brother Dr. Narcisse, I want you to speak to in terms of trends. One of the medical considerations out there is that there have been some pretty impressive improvements in sickle cell anemia care. We know that disproportionately affects the African-American community. Can you just take a second or two and talk about where we are in terms of our better ability to treat sickle cell?
Yes, I think that sickle cell anemia has had very little advancement for a long, long time, and increasingly we're seeing impressive benefits from very, very small early trials of looking at, say, stem cell transplant. And I think that the individuals who have been enrolled in those trials have done so with great courage, but they found very, very impressive results. Now, that doesn't mean that every single patient with sickle cell needs to go out and demand that their physician give them a stem cell transplant. They're very, very, very narrow indications for that. But I think that that's a great example of advocacy turning into results. And I think that whether it's disparities in healthcare or something much more in an abstract sense, or something more specific in terms of, hey, I want to call my congressman and ask them to increase funding for sickle cell anemia research. I think that those are the kinds of things that have begun to pay dividends. And I think that we need more of it. They need to hear our voices because representation matters.
Indeed, indeed. So, what I heard there is that this is the type of thing that if you have a family member who has sickle cell, this is part of information that you should be making yourself aware of. Not everyone's going to get the stem cell modifications, but it's something that you should talk to your doctor about so that you know when you might when that might be indicated and what other advances are going on, because as was pointed out, we've just been devastated by it for so long that, get some good news, have your conversations with your docs.
And in this particular case, if those people who received stem cell transplants successfully were cured of their sickle cell anemia.
That's right. That's right. So I have my last two questions are for both of you, and I'm going to start with one. As the boomer generation is pretty much in full throttle aging now, probably up to, I'm not going to do the math, but at Medicare and above age. Let's talk about the physical and mental considerations in terms of what this population needs to know about the ongoing ability to function at a higher level. How have trends in both mental and physical health advanced to where the boomer population, and we'll do the inverse subsequently, what should they know about how they're going to live the next 20 or 30 years? Let's start with you, brother, Dr. Bailey.
Well, I'll jump in and very quickly say that the information on our end is very promising. First and foremost, anything that shows a better sign, I think, of longer, more healthy living than moderate exercise. We've gone from early in my career saying 3 times a week to now it's 5 times a week. It's just every day. Doesn't have to be, lifting heavy weights, although some weight resistance training I think is beneficial. Doesn't have to be hours and hours, probably 20 to 30 minutes. But some exercise, even something that's pretty straightforward as walking, is remarkably helpful in how the brain, when the brain functions well or doesn't deteriorate, it keeps sending the correct signal to all of the organs throughout the body. So exercise, number one. In addition, I think that we are appreciating some treatments for persons who, as they get older, a lot of our initial issues, these agents that we work for, dementia, speak, from declining faster. There's certain treatments, one, Amanda is probably most substantial. But I think now we look at combination treatments that can be helpful to the limitation of the decline in brain function, supposed to be called executive function, memory and concentration and attention span. So I think we clearly have some positive signs for people. Share with your friends and relatives and older relatives that are beneficial and useful.
Yeah, I would echo that exercise is the thing that we see providing incredible benefits. And so, as mentioned, I think that the recommendations are now at least 5 days a week, and a half an hour every day is really the aspirational goal. And just walking is a great place to start with that. Additionally, very good control over diabetes, high blood pressure, high cholesterol in earlier life, middle age. We have so many more medications, so many more methods of managing these chronic diseases that always seem to cause strokes, heart attacks, and significant disability, Now, if we can better control those, they have both physical and cognitive benefit. So know your numbers, do your exercise. These are important things for long-term life and long-term wellness.
Yeah, so I'm going to take privilege here since we're talking to a lay population, and I've taken to just substituting the word exercise to activity, because people think of exercise as having to get up, pack a bag, and go to 24-hour fitness or something like that, when, as you point out, the simple activity of walking, and this is all about blood flow. Anything that improves your blood flow improves your cardiovascular output and function. Same with your brain, and same with other abilities to function and perform. So just stay active, stay healthy, and that'll keep us. How far off do you guys think we are from getting some meaningful advances in the treatment of Alzheimer's and other dementias?
Well,
So
I speak
you first.
pipeline. I think that these things, though, very often are years or decades away. I do think that what was better, though, is the side effect profiles, what most patients come to be complaining about, maybe a bit more modest. So be more able to tolerate medications and kind of go forward. What was very often, you take those medicines in combination with the meds that you just mentioned for a lot of the typical chronic illnesses, hypertension and diabetes, asthma, and the like. A better ability, I think, to find them blend in, I think, combination therapy is likely to work over. Other point I should make is in the Black community, we tend to see more so-called CI, a mild cognitive impairment, even before. So if you have some early signs, make jokes about it, or I'm having early, probably are. And that's the point, to really engage early. Shirley points out, some of the difficulties is long history, Brother Monteith, of untreated or undertreated hypertension, high blood pressure, and diabetes. So being very aggressive and assertive in how we treat chronic illnesses during this middle third of our life, between ages 60, goes a long way toward being effective. I think once you pass age 60, we think about regarding a cognitive impairment like dementia.
How does that sound to our resident gerontologist over there?
Yeah, I think that I've done a lot of advocacy work for the Alzheimer's Association over the years, and it's very clear that the Alzheimer's community is very, very excited about the new monoclonal drugs. The newest one, lecanemab or Leqembi, has changed the way that we look at Alzheimer's disease, and there's while that drug may or may not be the end all be all cure for Alzheimer's that we wish it to be, it points to new methods of identifying individuals early and trying to treat the problems that cause the symptoms of Alzheimer's disease before the symptoms develop. And that's a strategy that we'd be very, very excited about for the long term.
Well, actually, it's important to point out to the audience that there actually is a monoclonal antibody that actually is now FDA approved, right?
Leqembi or lecanemab.
So again, that's some empowering information for the audience out there. Last question for you both. We'll stay with you, Dr. Narcisse. Let's talk about our college-aged brothers and others in the audience out there. As you look out over what will be the next 50 to 70 to hopefully 90 years of your life, what's your best advice, and this is to both of you, for college-age individuals to plant seeds that will produce longer, healthy, and happier lives based on the trends that we see and how medicine is and mental health are evolving?
Do what I say, not as I have done in this particular case. I think many of us in my generation really focused very heavily on school, or very heavily on their professional lives, and I'm guilty as charged as we speak, as I sit. But I think that the understanding of the balance of our healthy lifestyle and the activity, understanding the importance of nutrition, not just dieting, are the kinds of things that would lead to better long-term outcomes. And I think that as I could speak to the college age younger me, and as I tried to educate my teen and preteen sons, I really think that wellness and healthy lifestyles begin with nutrition, and they must require greater activities than my generation thought was required.
Thank you. Thank you. Very nice. Brother Dr. Bailey?
Couldn't say it better. It's about health and wellness. I think as Brother Narcisse points out, I think very articulately, it's about balance. It's not to one's advantage. Yourself or your family or your community in any area. And too much work can be problematic, too much other difficulties. Goes without saying, we really should avoid toxic substances. We shouldn't think that marijuana is irrelevant, and we can experiment issues earlier because our bodies are younger and healthy. We can kind of handle them. That can have a short-term adverse effect and a long-term remarkably deleterious effect. I also think that family matters, and I think we should say on settings like this, if you can keep your family intact and have a spouse and have a good quality relationship, it goes a long way to, I think, strengthening and enhancing your emotional health, decreases, I think, stock market like ups and downs of emotional upheaval in one's life. And I think it provides protection emotionally for the times when things are difficult at work or with disaster if you live in a place like New Orleans or the case may be. Those, I think, are the big three: family, healthy balance, and avoiding, I think, adversity with toxic substances.
Thank you for that. So, one of the things that I tell my son that I hope that he has retained, it's a variation of the consideration of that youth is wasted on the young. I describe as one measure of success how successful you can become in this life, mentally, physically, spiritually, and otherwise, is how rapidly you can learn the things that you are going to have to learn eventually. Okay, so the sooner that you learn what you're going to end up having to learn eventually, the better off you're going to be. And in this particular example, you're going to end up, as these two physicians just said, you're going to end up wanting to cherish your family, wanting to treasure and protect your health, finding happiness, discovering that happiness is a choice, not something that somebody else makes you. The quicker you find these things out, the better off you're going to be. And Lord help you if you're 20 years old, and if we at 20 years old had all of those tools in our toolbox and actually implemented those things all day, every day, I think that it's just a formula for an absolutely fantastic life. As we do, I just want to thank two people that I'm proud to call colleagues, and even prouder that they would consider me their colleagues. I thank Alpha Phi Fraternity and our General President, Willis Lanza III, for continuing to support this forum. I want to thank our very engaged and fantastic audience for the great questions this evening. Come back to this space at our regularly scheduled time, 7 p.m. Eastern, 6 p.m. Central, 2 weeks from today, where Brother Dr. Narcisse will host our next Surgeon General Initiative event. And I am Alpha Surgeon General Jeffrey Sterling saying good night and thank you for your participation. Be well, be safe.
Good night.